and Kay was friendly enough and helpful enough to change my MAT to MOUD, which is still hard. The muscle memory is not quite there yet for that. But we're going to look at the prevalence of diversion in MOUD, including Ohio, look at some of the risks and appreciate some of the strategies to reduce diversion. As I tell you all, I typically look at the literature about every 3 or 4 months for these and update as necessary. Last update I did was June. I did look June 2020. I did look recently and didn't see much new. So I think this kind of captures what's out there right now. So again, this is really easy for me to be as a psychologist who doesn't prescribe medications, but this is the kind of the synthesis of the literature. If you look at it, is that the basic kind of themes are that buprenorphine is diverted in the United States because there's so many regulations which restrict access. So as you all know, as those of you who prescribe, you know there's restrictions on your side that can make it concerning to prescribe buprenorphine, but then on the patient side as well. So the argument is that some of the regulations actually make it harder for patients to get buprenorphine, and therefore there's more of it on the street. As well as the other kind of theme takeaway when you look at the literature overall is that the risks, even if you consider that there's a proportion of buprenorphine that's getting diverted, that really still the risks of that are far less than the benefits of having increased access to buprenorphine. So those are kind of 2 takeaways themes, as well as the third is that I can't spell illicit apparently, would be the 4th theme, or the 3rd theme to come up there. So like a lot of things in the MOUD world, there's things that we do that you know, that we believe are best practices, but there's oftentimes not really a evidence base to really evaluate the effectiveness. And that certainly, this is a 2014 study, but nothing's really changed. There really is a lack of controlled studies that look at what are some things that we could do to make buprenorphine less likely. So that's somebody's dissertation there. So definitions, and I say this all the time, I guess because it annoys me, and it probably annoys you to hear me say this, but if you look at the United States literature, they always conflate misuse and diversion. They lump them together. Fortunately, our European colleagues are much more specific and precise because they're very different things. But misuse is not what we're going to focus on. We focused on that before, but that's the person using their prescribed medication, but in a way that varies accepted medical practice. So, you know, snorting their medication, injecting their medication, taking a higher dose than what was prescribed. Diversion is what we're focusing on. And we hear a lot on here where patients will at least say there was involuntary diversion, right? Like my girlfriend or my boyfriend or my significant other stole my medication. That would still be considered diversion. We would argue it may be a good idea to get a police record of something like that happening, but nonetheless, that would be considered diversion. And it's the voluntary or involuntary unauthorized rerouting or appropriation of a substance. So that's what we're focused on today. So what about prevalence of diversion and MOUD? So in kind of that 18 to 20% is probably a pretty good estimate when you look at the literature. That kind of percentage continues to come up. So this was a survey of patients, and this was both for folks in methadone and buprenorphine treatment, and they found that about 18% sold, gave away, or shared their prescriptions. Studies also, you know, people look at different formulations and determining whether or not there's some that are more frequently diverted. And again, I have to put abused and diverted there because our American friends lump them together. Found that all 3 are abused or diverted, though sublingual film is typically the least likely to be abused and diverted. And you'll also see in Ohio that in general, a person could earn more money selling their tablets rather than their films. So there does seem to be that kind of translates to what we see in Ohio as well. So I had to miss, unfortunately, because I've been dealing with some health issues. I had to miss our presenter who, the researcher who oversees these Losammogram projects. I think we had him about a month ago. Really wanted to see him. It's very interesting literature. It comes out about every 6 months. Essentially, how these studies are conducted are they have surveys with people who are using drugs, with first responders, with criminal justice folks, and with people in the drug treatment field. And the idea is to kind of get a sense of what is the landscape, as opposed to the landscape of drug use in Ohio. So this was in January 2019, or this report went from June 18 to January 2019. So they found that the combination product was highly available throughout Ohio. That's basically been the same for 3 years now. They saw sort of spikes in the Cleveland area, Akron, Canton, and the Athens area, but basically pretty prevalent everywhere. When they asked folks, well, why is there all this diverted medication? Folks would say, well, it may be clinics where there's very little patient oversight, or the dreaded dark web, which I'm always warning my children about. And that also Suboxone is used as currency, so people might use their Suboxone to basically trade barter for other drugs. And some of the slang people refer to it as is octagons, rounds, subs. So that's a little bit about, a little bit more in Ohio. So when they ask why were you using diverted Suboxone, people will say that they were using it most often to avoid withdrawal. And kind of on that note, there's a correlation nationally and in Ohio where a correlation, not really quantitative, but people will discuss the relationship in a qualitative way, that when there's a batch of heroin, or we may say it really was a batch of fentanyl that's going around a particular community, and if there's a number of people who are overdosing and dying, which happens periodically, where you'll hear about like 20 people overdosing in one community, that there's a group of people who get very frightened by that, and then they will really try to access diverted Suboxone during that period, so to avoid overdose death. There always is a group of people who will also then go chase that drug that's killing people. There's kind of two groups like that. So in general, and it does vary by region, an 8 milligram film strip of Suboxone will get you around $10 to $30. Whereas the tablet would get you around $20 to $25. That what I was referring to is that in general, on average, you can earn a bit more for a tablet than you could for a film strip. And here we get into a little bit of the abuse, and most people, or misuse, I should say, most people who took diverted Suboxone took it orally, though there was that group, and there's always this group, including those who are in actual Suboxone treatment, who will continue to intravenously. And I know that we will always say, well, that's why naloxone's on board. Why are people using intravenously? You got me on that. I have no idea, aside from these folks, this 10 to 30% that just kind of consistent will say they feel the euphoric effects of injecting their Suboxone. So this was a study in 2019 where they surveyed folks that represented 18 different Ohio alcohol and drug mental health service boards. And they were wondering, and they published the study in 2019, but they did the surveys in 2015. They must have had to make a lot of changes to their paper to get it published. But they found that they were asking, what were the perceived barriers of diversion? And Child Protective Services and law enforcement came up frequently. And this is just a quote. The public as well as law enforcement was having issues with Bupe being sold on the street, diversion, those kind of things. So there seems to be, a sense that if law enforcement, Child Protective Services, or the public in general is very concerned about buprenorphine, that it might then become harder in that county or that region to provide access. And it kind of makes sense because so many patients are are involved with child protective services or with criminal justice system. So it kind of dampens, for all of those folks, their ability to access buprenorphine. So what is the rationale? Like, why are people doing it? This is a 2015, 2016 study of 200 folks. And what they found was 22% of the folks said that it was okay to share buprenorphine with a dope sick friend. So that kind of gets to that Ohio avoiding withdrawal thing. Around 38% said it was okay to share buprenorphine to save lives. That again gets at that theme of there's the quote unquote bad batch out there, that people are going to be more open to sharing their buprenorphine with their friends. And then about 52% of the sample said that it's not okay to share or divert, and they basically would not do it. Of those 107 who did endorse diverting from time to time, 59% it was helping a friend, 57% said they needed money. And this is where I would say right now, you probably all have patients that are struggling financially, maybe more so than they had been right now. So this would be a time to wonder whether or not making ends meet financially is a stress, and if that might be a factor that contributes to people diverting their buprenorphine periodically. 27% they didn't need the whole dose. So that's that whole issue where we try and ensure that people are getting the adequate dose. And even when people say, well, I still feel a little sick, we might use something like COWS or some other objective assessment to determine whether or not it seems that they really are in withdrawal and need a higher dose or not. 59% didn't want the whole dose or wanted to get high. And you do hear reports of people, I think about it like Adderall. With Adderall, you talk about drug holidays, which is for a different reason. It's just you don't need it for a while, so get off of it for a while. Maybe you're not in school or something. But this is more, I want to feel the euphoria of using heroin, so I'm gonna stop taking my buprenorphine for 3 or 4 days and experience the heroin high, and then get back to my buprenorphine after that. Consequences of diversion. It certainly can have some harmful medical consequences. It can include overdose, because these folks who are accessing diverted medications aren't engaged in medical treatment, and therefore there's no one to monitor how they're doing medically. Clearly, it can lead to harmful social consequences. You can, certainly it's illegal, so you can catch a case, as they say. You could get involved with child welfare, which people typically want to avoid. And it can jeopardize treatment participation, right? Like you all, from time to time, have to discontinue treating patients who are consistently diverting their medication. And then that affects that individual's access, but then over time, it's theoretically could limit access overall if there's the belief that too many people are diverting. However, in general, the safety profile of buprenorphine is superior to methadone. And there appears to be actually less drug diversion, and Chris Dos Reyes taught me why. Just last time I presented, I never thought about more the pain methadone issue. I'm more familiar with methadone maintenance, where you're going every day, and that seems very hard to divert. But from folks who are getting it for pain and not going to for opioid use disorder, that would make sense. More than 50% of buprenorphine-related emergency visits are for non-medical use. So the majority of folks who are going to the ED for buprenorphine were essentially either overusing or were receiving diverted medication. And there is a risk certainly for children. So I know that, many people in their treatment contracts for their patients have language around how they're going to safeguard these medications from their children. And like we talked about with domestic violence shelters, because there's children oftentimes sharing rooms with people like there's a couple of clusters of families. That's a reason why domestic violence shelters will say they won't take patients who are on buprenorphine, because they don't have a way of safeguarding the buprenorphine. We can all argue the merits of that, but that's one of the rationales. So I think this is an interesting study. This was 2018, and they were essentially it was somewhat of it was a geographically stratified sample. So they were trying to get, it was 1,100 or so prescribers. And they were trying to kind of tap prescribers from all over the United States. And they were trying to look at basically sort of what were some of the factors that contributed to their attitudes towards diversion. So first of all, what did they do? So about 80% assessed via urine drug screen for presence of buprenorphine. The literature did not specify whether they were looking for the presence of norbup as well, which we all know is really one of the things you would need to assess, because people can dip their medication in their urine or what have you, and buprenorphine will come up, but really you want to see if their body metabolized it, I guess is the right word. But no, the norbup, so they didn't specify whether they're looking for norbup, but we know that that's good practice. 35% saw patients 2 times a month during the first 60 days. About 27% saw patients one time a week during the first 60 days. So just that idea of recovery is very hard, early recovery is very hard, and therefore it can be helpful to have increased oversight. 66% initiated medication counts, so had folks come in periodically to do medication counts. This is more from that study. So about 50%, and this is kind of a Likert scale, obviously, so you kind of go from disagreement, agreement, strong agreement. So 50% had a strong agreement with terminating patients who are diverting. This also didn't specify whether, okay, is one time, are you going to terminate somebody who diverted their medication one time because they had a friend who, was dope sick? Or were they talking about someone who was trying to be an entrepreneur and really had no interest in treatment and was just trying really to divert medications? They didn't specify, and I think that's important an important distinction. 30% agreed with terminating patients who are diverting, so a little bit less than strongly. About 50% reported diversion was a moderately significant community problem. About 24% reported it was a significant problem, and about 12% reported as extremely significant problem. So, about 90% of the sample, their community was concerned about diversion. And so then they wondered, okay, well, I wonder if there was an association between the perception of the community problem and whether or not the people were more likely to terminate patients. And they did find that there was slightly increased odds ratio of a prescriber terminating patients in a way that was associated with the perception was a community problem. So it kind of makes you wonder whether those were individual decisions or whether or not those were in some way affected by the sense in the community of what was going on with diversion. And also our psychiatrists and addiction specialists, which I think is really interesting, were less willing to terminate treatment compared to other types of prescribers, the non-addiction, non-psychiatry prescribers. I always think that's interesting that showed up. So what can you do? So, initially, especially, kind of they just, they borrowed what was happening in methadone maintenance treatment programs. So they were kind of borrowing from what was happening there to figure out whether or not they should be concerned about diversion. So in methadone maintenance, you may begin to give people take homes or, unobserved dosing. If you had a patient for some period of time, there were no recent drugs of abuse, including alcohol. They were coming to the clinic regularly. There were no serious behavioral problems at the clinic. No known recent legal activity, stable home and social relationships. They had been in treatment for some period of time. Assurance that the medications could be safely stored. And there's always this thing like, does the rehab benefit outweigh the risk of diversion? And I've talked before about when I worked in methadone maintenance in New York City. I can remember some people, and one guy in particular, where this is a guy with, the guy in particular, most people I worked with had multiple felonies, 3 to 4 felonies. Getting employment was incredibly challenging. And when we would believe that employment is a really important part of recovery. So you got a person who's, this guy got a job as a welder, making really good money. But unfortunately his work schedule, which he showed us, made it pretty much impossible to come to the methadone clinic every day, right? So there's a big discussion about him and others like him of what to do. And ultimately the decision was made that, hey, this guy with 3 to 4 felonies having a job as a welder which he verified. Maybe we need to give him a little more leeway, see how it goes, right? And that's what we did. And I tell about this guy, not that a Corvette means that someone's having a successful recovery, but the guy would drive up in his Corvette after about a year and a half, and was actually a very positive person in the facility and gave back in many ways. So we were really happy we made that decision for him. So more in like office-based opioid treatment, what can you do? So, you know, this is a little bit more specific to that rather than just to methadone. There's urine tests and bup metabolites and other drugs of abuse. You're going to want to screen for that. Pill counts and medication log. I know some of y'all do that, some of you don't. Some of you in your treatment agreement indicate to patients that they're going to work with you, that there could be a 24 to 48 hour response, that if you call them, they're going to need to come in for unannounced random targeted urine test and a pill count. Observed ingestion. I know this is a heavy lift for many of you. Some offices can do this, some can't. But where the folks that you're kind of concerned about with diversion, then maybe you're having them come in 3 times a week, or giving them a limited supply of medication, as little as a week or as little as even 3 days. Obviously, you always want to look at your Ohio automated prescription reporting system. And you may also, which you know is getting more and more prevalent, is thinking about buprenorphine extended release injections or the buprenorphine implant, because hopefully those things are hard to divert, but I wouldn't put anything past anybody. What else can you do? Discuss diversion and misuse regularly with each patient. You know, and even like I mentioned before, not in an accusatory way or even a way that is suggestive, but I would wonder with patients, how are you doing financially right now? What's going on with you financially? How are you making ends meet? And just try and get a sense of if financial stress is an issue, because it is for a lot of Americans right now. And you also may want to help people understand what are triggers for diverting. And oftentimes people with substance use disorders, and the research bears this out, can be kind of passive. You don't think about that because sometimes they're angry and you know, in your office and such. And this is where I'll say I'm also a person in long-term recovery, and I've been both. I've been passive and I've been a bear as a patient. I've been both things. But so, you know, sometimes there is a passive style, and people, you know, are kind of walked on to some degree, and maybe helping them be more assertive about, no, these medications are for me, and I'm not gonna share these medications, and helping people get some language around that. I know that this is where also our pharmacist friends can be involved. I can remember some of you were saying on here that, which I've been aware of too, that relationship with the pharmacist can help a lot, because just one example was where it was clear that there were a number of people outside of the pharmacy who were buying people's buprenorphine on the way out. And there was a conversation between one of you and the pharmacist, and said, hey, for this person, it may be a good idea to transfer their medication to another place where that wasn't quite as much of a risk. Regularly reviewing and monitoring the dose adequacy, like we mentioned, just to make sure people are getting the sufficient and adequate dose and not getting a more of a dose than they really need, because then that could be diverted, right? This gets more to abuse, but examining any kind of track marks or intranasal agitation, things like that. Contingency management, it is an evidence-based practice. It can be hard to do in some ways, but essentially trying to find ways to reward people for recovery behavior. So some places I've worked at, we gave people bus tickets and things like that for having expected drug urines results. But even so, there may be some patients who really like to see you all regularly. So it wouldn't be a reinforcement to allow them to see you less often, right? That would actually be kind of like punishment. But for some of you, and for some patients, I should say, it may be a benefit to see you less regularly. So therefore, you know, you can continue to extend out the amount of time that they have to see you based on their recovery type behaviors. Treatment agreements, which we talked about, collaborating with treatment partners, which we talked about. This is where you also really want to think about your, are there non-using pro-social, recovery-oriented family members. That can be really hard. I remember Dr. Robbins was talking about that a few weeks ago. It can be really hard to know whether a significant other is a positive influence or not. It's very hard to know. But you know, use your best guess. And sometimes those folks could tell you, yes, I'm watching my son ingest their medication. I'm watching them each day. And that's a way that you wouldn't have to have them coming in the office as much if you could trust that loved one. Access to full psychosocial treatment, obviously, because the MOUD is an incredibly important part of treatment, but for many folks, they also need other types of treatment to help them avoid diversion, but also to promote their recovery. And consider the patient's rationale for diversion before intervention. So getting a sense of why did they do it. And we talk a lot about how it's much easier to work with someone that you feel like is being open about what's going on rather than someone that seems gamey and untruthful, because it's hard to know how to help if they're not telling you really what's going on. So just I'm going to spin through this really quick. I only add this because we were asked about it a few months ago. There's a lot of flaws, like all research studies there's a lot of flaws with these research studies, excuse me. And unfortunately, all three have kind of the same flaws. So basically, you know, don't take this to the bank. Essentially, they're trying to look at sort of bup and norbup levels and what might be red flags for diversion. So patients where there was no concern about diversion, the buprenorphine was like only 4% of those patients where there's not a concern had a level over 1,000 nanograms. Patients who were actually saying that they were adulterating, 43% of those folks, their buprenorphine level was over 1,000 nanograms. And then patients who were suspected of adulteration, their buprenorphine was greater than 1,000 nanograms of 40%. So kind of that 1,000 nanograms higher than that was one of the things that was looked at. Compared to no concerns, patient with concerns had significantly higher bup and lower norbup levels and a lower norbup to bup ratio. And these authors argue, again, this is not to take to the bank. This is just what these folks, what they arrived at was a buprenorphine level higher than 700 nanograms offered the best accuracy for discriminating between adulterated and non-adulterated specimens. So this was a study with just 33 patients over 25 weeks. And they're kind of looking at the outcomes of the first 3 urine drug tests. And again, looking at the frequency of bup positive and norbup negative samples. So the first sample, about 18% submitted problematic sample, which is to be expected, right? These are folks who are just kind of getting into the recovery process. Subsequent samples, an additional 3 patients. So you pick up another 3 that had problematic samples. So it seems like kind of, and we talked about this before, there's some patients who seem to have trouble out of the gate and they may continue to have trouble. And there's no statistically significant association between discordant samples and buprenorphine dose. So obviously there was the wonder, okay, if it's too high or too low or what have you, but they didn't find that to be the case. Retention to the end for the treatment concordant. So folks who were submitting more treatment concordant toxicologies, 96% of them made it through that period of time. Retention to the treatment to the end, 3 out of 9, 33% were retained. So, you know, it's kind of what you'd expect. The people who had trouble out of the gate were less likely to stay involved in treatment. And again, they argue about that same norbup-bup ratio of 0.26 being the ultimate cutoff. And then, so this was a sort of a case study again, looking at discordant bup, norbup levels. And these were for patients that were submerging their bup and naloxone strips in the urine to mask illicit drug use. The authors recommended a number of things. So harm reduction first, the idea that in general, yes, diversion needs to be considered a serious issue, but sort of what's the risks and benefits based on the person's behavior, rationale, and their frequency of engaging in that behavior. also argued how important it is to create a relationship where your patients can be honest with you and open, and not feel judged by their behavior. It doesn't mean there's not consequences. You can judge people. There can be consequences and not judge people, right? Those two things don't have to co-occur. And a non-judgmental and normalizing attitude. So again, these folks also argue this Norbupe-Bupe ratio of 0.26 is a good cutoff. They also argue that buprenorphine levels over 700 nanograms is going to help you with detecting urine adulteration. And again, they argue that even when you have these just discordant findings, that you should be looking at the totality of the person, not just this one lab. I know Drs. Marsh and Dels Reyes really always highlight that's just one piece of data, and you really want to look at multiple pieces of data before making any decision. So, you know, since I'm a psychologist and we're talking about labs, I get my good friend, Dr. Marsh, or someone involved just to see if her interpretation was similar to mine. And essentially, so when we look at those 3 studies, which is really what's out there right now, there's flaws with all of them. There's internal and external validity concerns, and they're all in the same way. So there's a problem with that research base to this point. The take-home point is there really should not be significant amounts of buprenorphine in a urine sample that's not been adulterated. And also there should be significant Norbupe. So, you know, that's kind of what you're looking at. And that these ratios that I just presented on a level shouldn't be used as like forensic style cutoffs, but they could be then an opportunity to have those kind of Columbo type discussions like, you know, sometimes when this happens, this is what's going on. I wonder what you think is going on, right? In more that kind of way where it's a discussion, but not accusatory. And those are my references. So I'll stop share now. So let me open it up to any, I cannot look through all